This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alara, Research Fellow. Today we're looking at a fascinating new study from the Chinese Journal of Reparative and Reconstructive Surgery, published in 2026. The study focuses on a specific clinical dilemma: how to choose the opening side for a unilateral open-door laminoscopy, or UODL, in patients with cervical ossification of the posterior longitudinal ligament, OPLL, when there is a symptom ossification mismatch.
This is a classic surgeon's choice scenario, Ilara. When we perform UODL for multi-level OPLL, the goal is to expand the spinal canal volume and allow the spinal cord to drift posteriorly. Usually, if the symptoms and the largest part of the ossified mass are on the same side, the choice is easy. You open on that side to provide direct decompression. But as we know, clinical symptoms don't always align with the imaging.
Exactly. The researchers call this symptom ossification mismatch. It's a situation where the side with the more severe ossification on CT or MRI is actually the opposite side of the patient's most severe clinical signs and symptoms. The question is, do you open toward the symptoms or toward the bone?
It's a contentious point. Some argue for the symptomatic side to address the clinical priority, while others suggest opening toward the larger ossification to maximize the space for the cord to shift. Walk us through how the study was designed.
This was a retrospective analysis of 89 patients treated between January 2020 and January 2024. All patients had multi-level cervical OPLL, involving at least 3 segments, and had failed at least 3 months of conservative treatment. They were divided into 2 groups based on the opening side. The ipsilateral group had 41 patients, where the opening was directed toward the side with more severe ossification. The contralateral group had 48 patients, where the opening was toward the side with more severe symptoms.
And I noticed the baseline data was quite balanced.
Very balanced. There were no significant differences in age, BMI, or disease duration. Even more importantly for our listeners, the radiological baselines, like the ossification length, the Pavlov ratio, and the C27 Cobb angle, were comparable between groups. Both groups were also K-line positive.
That's crucial for a fair comparison. Let's get into the results. How did they fare clinically?
In the short term, both groups did very well. They followed the patients for an average of 19.3 months. At the last follow-up, both groups showed significant improvements in their VAS scores for pain, their Neck Disability Index, NDI, and their JOA scores. However, and this is the key finding, there was no significant difference between the 2 groups in terms of how much these scores improved. Whether you opened toward the bone or toward the symptoms, the functional recovery was essentially the same.
That's an important point for residents to hear. Often we worry that if we don't open on the symptomatic side, the patient won't improve as much. This study suggests that as long as you achieve adequate global expansion of the canal, the clinical outcome is robust. But Ilara, the study did find some significant differences in the imaging, right?
They did, and this is where we should dive deeper. While the opening width and opening angle were similar in both groups, the researchers looked at the spinal cord diameter ratio and the spinal cord posterior shift distance.
Tell us about the posterior shift. That's the bowstring effect we aim for in laminoscopy.
Precisely. At the last follow-up, the ipsilateral group, those where the door was open toward the larger ossified mass, showed a significantly greater spinal cord posterior shift distance compared to the contralateral group. Additionally, the change in the spinal cord diameter ratio was significantly better in the group where the opening was toward the ossification.
So even though the clinical scores were similar at 19 months, opening toward the ossified side actually resulted in a better morphological recovery of the spinal cord and allowed it to drift further away from the compressive mass. Why do you think that is?
The paper suggests that by hinging on the side with less ossification and opening on the side with more severe bone growth, you create a larger effective space specifically where the compression is most intrusive. This allows the cord not just to move back, but to reshape itself more effectively.
It's a compelling argument. If the cord has more room to shift away from the largest peak of the ossification, you theoretically reduce the risk of long-term attrition or dynamic injury. Even if it doesn't show up in a JOA score at 1 year, it might matter 5 or 10 years down the line.
That's exactly what the authors conclude. They mention that the impact of this radiological advantage on long-term clinical outcomes, beyond their 2-year average, requires further investigation.
Let's talk complications. In any cervical posterior procedure, we worry about C5 nerve root palsy and axial symptoms. Did the side of the opening affect these?
No. The study found no significant difference in the incidence of C5 nerve root palsy or axial pain between the two groups. The overall complication rates were comparable. This suggests that opening toward the more heavily ossified side doesn't necessarily increase the tension on the nerve roots in a way that leads to more palsy, at least not in this cohort.
That's reassuring. Sometimes there's a fear that a greater posterior shift, which we saw in the ossified side group, might lead to more tethering of the nerve roots, but that didn't manifest here. What about the surgical metrics? Operation time, blood loss?
No differences there either. The perioperative parameters, including hospital stay, were almost identical. It shows that choosing one side over the other doesn't make the surgery technically more demanding or more morbid for the patient.
So if we're summarizing the take-home for a surgeon standing in the OR looking at a laminectomy set and a patient with a mismatch, what's the verdict?
The study concludes that for patients with multi-level cervical OPLL and a symptom ossification mismatch, UODL provides similar clinical symptom relief, regardless of the opening side. However, opening toward the side with more severe ossification, the ipsilateral group in this study, is superior for spinal cord morphological recovery and achieving a greater posterior shift.
It's a nuanced result. It moves us away from the dogma that you must open on the symptomatic side. If opening on the ossified side gives you a better radiographic decompression without increasing complications, it might be the more sound mechanical choice for the spinal cord's long-term environment.
Agreed. It gives surgeons the evidence-based confidence to prioritize the side of maximal ossification when the mismatch occurs.
Well, this has been a great deep dive into a very practical neurosurgical problem. Thank you, Ilara, for breaking down the data.
Happy to do it.
To our listeners, we hope this helps the next time you're reviewing a CT myelogram for an OPLL case. For more episodes and surgical insights, stay tuned to the Neurosurgery Hub podcast. I'm Dr. Aris.
And I'm Dr. Ilara. We'll see you in the next one.